Now let's start with the next topic, and that is tolerance and autoimmune disorders. Now autoimmune disorders is something that you will be studying it once again in medicine also, other than path and micro. But tolerance is something which most of the students tend to skip in all the three subjects. So let's get over that once and for all. Let's stop procrastinating and finish off tolerance in one go. Now whenever I talk about tolerance, tolerance is not autoimmunity. Tolerance is what I have, all of us have, and it is good for us. What do I understand by tolerance? Tolerance means that I am going to tolerate my body. This is the tolerance that we have to the self-antigens. This is the tolerance that we have to the self-antigens. Means my own heart, my own joints, my own skin, my own red blood cells, I'm tolerating them. I'm not going to kill them ever, right? So how many types of tolerance do we have? We have two types of tolerance that we have to know. One is known as a central tolerance and the other is known as a peripheral tolerance. And now I know it's a very dry topic, very difficult to learn. So I'm going to explain this to you with the help of a story of how you go to school and then you go to tuition classes and what all is going to happen over there. Okay, that is how we will learn it. So first let's start with central tolerance. Central, why did I call it central? Because it is happening in the central organs like the bone marrow, the thymus. It's all happening. So these are your schools. These are your main schools, right? Your school from 1st grade to 12th grade, you had school, bone marrow and thymus is that school. So now in central tolerance, we have two mechanisms. One is for the B cells, one is for the T cells. So the first central tolerance mechanism that you have is deletion or negative selection. What does that mean? So it's very difficult to learn it like that. Like I said, we are going to do it with the help of a school mnemonic so that it becomes easier. So Socho, when you're talking about a school, you will always have some or the other student who will be very, very naughty in school, who is not going to listen, right? So this means no matter how much you teach that kid, no matter how much you tell him that he doesn't have to do any mischief, he will always be naughty. He will not listen. He will break desks in the class. He will do a lot of naughty things, right? So what do? So first is you are going to delete or negatively select all of those kids. You're going to select those kids and you're going to chuck them out of class, that you are creating too much of nuisance. Let me chuck you out of class. So remember, all the self-reactive T cells, all the naughty students, all the self-reactive T cells are going to be deleted. That listen, you're not listening to me, you're breaking all the things in my classroom, you get out. Who does that? Obviously, a teacher or a principal can get out, can tell the students to get out. So which is the gene that is regulating it? Or if I ask you who is the regulator of this entire process, the regulator of this entire process is the AIRE gene. What is AIRE gene? AIRE gene means autoimmune regulator gene. Easy to learn now. Autoimmune regulator. It is going to regulate everything. So this is a school teacher who's regulating that. Are all the T cells working properly? If the T cells are being naughty, if they are being self-reactive, delete them. If they are being self-reactive, we are going to delete them. What if the school teacher is on leave? If the school teacher goes on a long vacation, everyone is going to have a blast. So what if there is a defect in the autoimmune regulator gene? The patient is going to have a disease called AIPE. What is AIPE? Autoimmune polyendocrinopathy. Autoimmune polyendocrinopathy is what the patient is going to have, and this includes polyendocrine disorder. So the patient is going to have multiple diseases like diabetes mellitus, like Addison's disease. Lots and lots of multiple endocrine disorders are going to happen in the patient. So please note over here, guys, that the story was that whichever is the naughty T cell, the T cell which is killing my own system, there is going to be a teacher called AIRE who's going to chuck all these T cells out, who are going to delete them. But what if the school teacher is on leave? What if I stop recording these videos? You are probably going to delay pathology and microbiology for as long as possible and not study. So if I am on leave, there is going to be some kind of problem that will happen, and that problem is known as autoimmune polyendocrinopathy. The first central tolerance mechanism is done. We can move on to the central tolerance second mechanism. What about the B cells? What about the naughty B cells? So this is a B cell. If it is saying that I will to be naughty and I will, kill my own system, every time the solution is not chucking someone out of the class. Every time I cannot do it. A good teacher is not someone who always chucks the students out of the class. A good teacher is someone who changes the students, who counsels the students, who mentors the students. So I am going to tell these B cells that, listen, I'm going to make them understand you don't have to kill your own system. I will make them understand you don't have to kill your own system. You have to kill bahar wale. You have to kill the bacteria, viruses coming from outside. So what am I going to do to them? I am going to do receptor editing for them. I will edit their receptors and they will be fine. So there are two things. Either I can counsel a kid or I can chuck him out of class. So when I counsel a B cell and I change his receptor that, listen, don't kill your own cells, that is receptor editing tolerance. If I chuck the student out of class, that is, I'm going to delete it. That is done for the self-reactive T cells and that is mediated by a gene called autoimmune regulator. So the two mechanisms are done. One mechanism is chucking the student out of the class, that is going to be deletion or negative selection, and the other mechanism is going to be receptor editing. Are the two types of school methodologies clear? Are we done with central tolerance? School mein kya kya hota hai? But tell me, does everyone go to school? No, na? Some people bunk school. Ideally, if everyone would have been going to school, then B cells and T cells both would have known that, okay, we are well trained, we have been taught very well, but everyone doesn't go to school, people bunk. Then who is going to teach them? Tuition classes are going to teach them. Coaching classes are going to teach them. So then, if central tolerance fails, if basically the school fails to teach the kids, who is going to teach the B and the T cells? The peripheral tolerance, the coaching classes are going to teach the B and the T cells. So what all comes under peripheral tolerance? Point number one, we've got a set of cells called T regulatory cells. What are T regulatory cells? Whenever I say any B cells or T cells or NK cells, any kind of cells, I say, what do? Do they increase your immunity or decrease your immunity? Obviously, we are talking about immunology chapter. They are all going to increase my immunity. But finally, I have a type of a T cell which is going to decrease my immunity. It is immunosuppressive action. It causes suppression. So what are these T regulatory cells? Because they are a little different. They are a type of or a subtype of CD4 T cells. They are a subtype of CD4 T cells. So they are not just CD4. CD4 hota to they would have been like regular CD4. They are CD4 T cells which have two things positive more. They have CD25 positivity. Do you know what is CD25? CD25 is interleukin 2 receptor. They have CD25 positivity and they are controlled by the FOXP3 gene. They are controlled by the FOXP3 gene. Let's do a recap. What are T regulatory cells? They are the only T cells. Rest all B, T, NK cells increase my immunity. These are the only cells which are going to suppress my immunity. Suppress my immunity matlab immunosuppression. And what are they? They are nothing but CD4 cells. Additionally, which marker do they have? They have CD25 and which is the gene that regulates them? FOXP3 gene. So guys, please have a look at this particular flow cytometry chart. Many of you might have gone through flow cytometry in Himayat. Many of you might be having it pending. But remember, you always have to look at the x-axis. X-axis over here is showing you what? The x-axis is showing you CD25. What is the y-axis showing you over here? The y-axis is showing you FOXP3. When I see these two markers, of course, I'm anyway thinking of T regulatory cells. But the examiner has marked this quadrant for me. He's saying what are the cells in this quadrant. So if I trace them, the cells over here, they have a good expression on the x-axis. Matlab they are CD25 positive. They have a high expression on the y-axis also. This means they are FOXP3 positive. What cells are these? The cells which are CD25 and FOXP3 positive, of course, they are going to be a type of the T regulatory cells. Okay. So coming back, these are the T regulatory cells which you can identify. But now you will ask me that how are they going to suppress your immunity? What do they do? So please remember, they are going to cause immunosuppression by increasing something called CTLA4 and PD, programmed death 1. They are going to increase it. So these are basically all molecules that I'm making a list for you. These are all the molecules that do immunosuppression. Someone asks you what all decreases the immunity in your body. So you will say the T regulatory cells decrease the immunity in my body. CTLA4 decreases immunity in my body. PD, programmed death. PD also decreases immunity in my body. So whenever I will increase T regulatory, CTLA4, PD1, all of these will cause immunosuppression. When we are studying so much, why don't we also study the diseases? guys, if there is an interleukin 2 receptor defect, if there is an interleukin 2 receptor mutation, what are the two diseases in medicine and surgery that you study? Interleukin 2 receptor, which intestine disorder? Inflammatory bowel disease. And which brain disorder? Multiple sclerosis. Remember, multiple sclerosis and inflammatory bowel disease, read their pathogenesis, they show you the CD25 or interleukin 2 receptor problems. Similarly, if I say that there is a defect in the FOXP3 gene, if there is a FOXP3 gene mutation, what does the patient have? Patient has IPEX. What is IPEX? So FOX में PEX. Fox में PEX. Now this is a very common confusion that the students have, which I want everyone to sort out in one go. देखो, दो genes होते हैं. So now going forward, we need to know the difference between two very important genes. And those two genes are FOXP3 gene that you'll read, and the other one is FOXL2 gene that you'll study. Very similar sounding, so we tend to get confused. Remember FOXP3, the way you say FOX, it reminds you of PEX. So what is the syndrome that it's going to cause? It's going to cause IPEX syndrome that you were studying right now. What is IPEX syndrome, guys? IPEX syndrome means, number one, there is going to be a problem in the immunity, immune dysregulation. Next, of course, all these immune disorders are associated with endocrinopathy. So polyendocrinopathy will happen. Also, taking the E separately, these patients are going to have enteropathy. And finally, there is going to be an X-linked inheritance that it has. Let's do a recap. We have immune dysregulation, polyendocrinopathy, enteropathy, and X-linked disorder that we have. That is what is associated with FOXP3. What is FOXL2? So we have always learned lady, FOXL2 for lady. This is associated with the lady tumor. Guys, you will study this in gynecology because this is the mutation in granulosa cell tumor of the ovary. This is what you see in granulosa cell tumor of the ovary. So FOXL2 should remind you of lady, so ovary, and FOXP3 should be PEX, that is IPEX syndrome, and that is what you were talking about in T regulatory cells. But why did I talk about these cells? What was I studying? I was studying the peripheral tolerance. Peripheral tolerance is that I have to teach the B and the T cells that please don't kill my own self. Don't kill me. So how, if they are trying to kill me, what will I do? I will activate these cells and these cells will suppress them. They are like an exam invigilator. Someone is trying to cheat. This invigilator is going to go and stop them. So if the B and the T cells are trying to kill me, these T regulatory cells will say, okay, let me check you, let me suppress you. It's going to go and suppress them. So that is one peripheral tolerance that we have. So if the students listen to me and they stop cheating, very good. But if the students don't listen to me and they continue to cheat, what is the second thing that I'm going to do? I am going to have to take away their answer sheet and chuck them out of the examination hall. If they continue to kill me, killing of the self-reactive cells. So remember, how does killing happen? Obviously, killing is going to happen by apoptosis, and apoptosis is mediated by which CD marker? Apoptosis is mediated by CD95. So now the problem is, if there is a CD95 or a FAS mutation, if there is a CD95 or a FAS mutation, there is a disease known as autoimmune lymphoproliferative syndrome that happens. What if I cannot chuck the students out of class? Problem na? So that is going to be autoimmune lymphoproliferative syndrome. So the second mechanism is also clear. The first mechanism was, if the students are not listening to me, I will suppress them by T regulatory cells. If they still don't listen to me, I will have to chuck them out of class. I will have to kill them. By what mechanism? By apoptosis. Apoptosis happens by what? It happens by CD95. And if CD95 is mutated, the syndrome is known as autoimmune lymphoproliferative syndrome. All said and done, the third is the most complicated peripheral tolerance mechanism where I want all of you to become super alert, and that is known as anergy. Anergy is going to be applicable to T cells also. Anergy shall be applicable to B cells also. So I will have to tell you two different things, one for T cell, one for B cell. For that, what I'll do, let me ask you that same story that I've been asking you since so long. Whenever an antigen comes into the system, which is the first cell which is going to pick it up? The first cell is antigen presenting cell. Okay, the antigen presenting cell is going to present it via which tray? Via the MHC tray, and is going to present it to whom? So for example, if this is the MHC, it is going to present it to the T cells. That is what we studied. So now I'm going to draw a big T cell over here, because now we have to study a lot of things. When this is a T cell, which is the receptor of the T cell which receives everything? Did we study T cell receptor is alpha beta? Yes, T cell receptor is alpha beta. So what did I say? Signal number one. What is signal number one? Signal number one is that when the MHC, when the antigen presenting cell and its MHC are going to give the antigens to the T cell receptor, that is the first signal. T cell will say, oh, antigen I have come to know. But T cell has a problem. T cell is like all of us. T cell never ever relies on one source. T cell says, I will not listen to only one lecture and one app. I will listen to that same signal from many teachers. Like the problem we have, T cell ko FOMO hota hai. That one signal alone is not enough. If you want me to work and want me to solve questions, give me another signal, confirmation though that this is actually coming. So now this antigen presenting cell has something called, it increases some molecules on its surface. It increases some molecules on its surface, and those molecules are known as B71 and B72. In other words, they are also referred to as CD80 and 86. They are referred to as CD80 and 86. So these antigen presenting cells say, okay, let me have this B71, B72, and they will go and bind to something on the T cells which is known as CD28. That will be signal number 2. Signal number 2 is what? When on the antigen presenting cell, the B71 and the B72 say that we will go and attach to what on the T cell? CD28 on the T cell. This is the second signal. This signal is known as the co-stimulatory signal. I need this signal, only then my T cells will say, okay, now I have got two signals. Matlab genuinely. Now I trust you. Genuinely antigen has come. Genuinely there is a problem. Now this T cell will say, okay, let me get activated. So what did you analyze? For a T cell to get activated, do you need one signal or two signals? Two signals. One signal is the usual one. Antigen presenting cell on a tray on an MHC is giving it to the alpha beta of a T cell. This is usual one. What is the second one I told you? That these B71 and B72 become too many on antigen presenting cell. They go and give a signal to something on the T cell called CD28. Because do you remember what were the T cell markers? 1 to 8, 28, but I never told you what 28 does. Now I'm telling you what 28 does. It is a co-stimulatory signal. It is going to help in signal number 2. So now my concept says that whenever I am talking about a foreign antigen, we will always need signal number 1 and 2. Only then the cells will work. Whereas I have made a rule that if I have a self antigen, there will be no signal number 2. There is no signal number 2. So for example, if this was my own antigen, my own red blood cells, my own heart, my own joints, my own antigen, this will be taken up, will be given. So signal number 1 to hoga. Signal number 1 is there. But what will I not do? Because I don't want to kill my own self. Na? So I will not have these molecules. I will not express these B71, B72, and I will not have any of these molecules. As a result, there is no signal number 2. No signal number 2 means the T cell will never ever get activated. That is known as anergy. Not having signal number 2 is known as anergy. That is the concept that we have to know. So repeating once again, whenever any foreign antigen comes, I have to have both signals, the signal number 1 and the signal number 2. But when I have my own antigen or self antigen, it is only signal number 1, it is not signal number 2, and that's a kind of a protection that I made because I don't want to kill my own self, and that is known as anergy for the T cells. Now, moving on to how do B cells maintain this anergy? But this process you already know. I'll draw something called the B cell and the T cell, which you have already studied. So B cell ye hai, and this is a T cell. And have I already told you that B cell is blessed with something that all of us really want? B cell is blessed with MD degree. B cell is blessed with MD degree, IgM and IgD. They are going to pick up the antigen. They are going to pick up the antigen and give the antigen to whom? They will give the antigen to the T cell. So is this signal number 1? Yes. What is signal number 1 for the B cell? Signal number 1 is going to be the antigen shared between the B and the T cells. Now, signal number 2 on the other hand was a chalice. You remember something? B cell had CD40 receptor, T cells had CD40 ligand, yes. So there is actually a binding between these two, and that is signal number 2. CD40 and CD40 ligand is the co-stimulatory signal in this case. And when this signal will come, only then the T cells release which interleukin? Interleukin 4, and interleukin 4 goes and changes that entire MD degree into what? Now we are going to have all the antibodies. Now we are going to have the GAMD antibodies. Yes, that was it, but that is only if it is a foreign antigen. Means when there is a foreign antigen, I have both signal number 1 and signal number 2. But if it would have been my own antigen, which signal would have been missing? I would have not done this chalice concept. No, I would have skipped signal 2. So remember, whenever be it B cell or T cell, signal number 2 will go missing, and that is known as anergy. So let's do a repeat. What do we mean by anergy in whether a B cell or a T cell? The problem is that if a bahar wala antigen comes, if a foreign antigen comes, I will have both the signals, 1 also, 2 also, and my cells will start working because I want to kill that antigen. But if it's a self antigen, if it's my own antigen, I am never ever going to stimulate signal number 2, because signal number 2 I don't want to kill my own self. So never ever have signal number 2 for B cells also, never ever have signal number 2 for T cells also, and this entire concept is known as anergy. So going all the way back, guys, we were talking about tolerance, and I told you there's something called central tolerance, then there was something called peripheral tolerance. Peripheral tolerance had 3 mechanisms. Number 1 mechanism was what? That you are going to utilize some suppressors like T regulatory cells. Second was you are going to do killing. If the cells don't listen to you, then you're going to kill the self-reactive cells. And the third protective mechanism that you've made is you are going to utilize the concept of anergy. Still, despite having, doesn't it always happen, despite having proper school, MBBS college, and also having coaching classes, can you solve 100% questions? You can never solve 100% questions. Means no matter how much you may try, some questions will always be cryptic or hidden. They will always be new questions. So despite doing so much, like this was a B cell, I took a B cell, I first sent him to school, then I sent him to coaching class. Why? Because I want this B cell ke, look at everything. Look at my antigen of the red blood cells, look at my antigen of the heart, look at my antigen of the joints, look at my skin, sab kuch dekh lo. You should know that, okay, flip through pages, get to know that these are all my antigens and you don't have to kill them. I ideally was teaching the B cells and the T cells, but there were some questions or some concepts which no one taught him. Why? Because they are very, very tough. They are hiding somewhere. Those are tough questions which are hiding somewhere. What are those sites? Those are the bet sites. Those are the bet sites. I bet no one has ever seen them. So I bet no one has ever seen them means there's the brain antigens. Brain antigens except area prostrema. Except area prostrema, but also area prostrema is shown, but other brain antigens are not shown. Second is going to be the eyes. Eyes except optic nerve. Eyes except optic nerve. And T for testis, testicular antigens, matlab seminiferous tubules and all are not shown except epididymis. Except epididymis. So repeating once again, what are the places which are not shown? The brain antigens are not shown, eye antigens are not shown, testicular antigens are not shown. So my B and my T cells have never read 3 chapters. They have never read 3 chapters. That is brain and eye and testis. They have never read. But brain mein thoda some important topics they have read. What have they been exposed to? Area prostrema they know, eye mein optic nerve they know, and testis mein epididymis they know. These important topics I have taught them, but other parts of brain, eyes and testes I have not taught them. So just imagine, for example, how did I hide them? How did I make sure that they could not be read? I was hiding them behind barriers. So they are made hidden by blood-brain barrier. For the brain, it is blood-brain barrier. For the eyes, it is blood-ocular barrier. For the testes, it is blood-testicular barrier. So I'll give you an example. Example, someone has trauma to the eye. Someone has had a trauma to the eye. Is the blood-ocular barrier going to break? Yes, trauma matlab blood-ocular barrier is gone. Suddenly, all the out of syllabus things have come out in the body. Suddenly, all these I antigens have come out. Out of syllabus questions have come. Are my B and T babies, are they used to seeing these out of syllabus questions? No. What are they going to do? They are going to start attacking these antigens. They will say out of syllabus, I have never studied. They will create a big hue and cry out of it. They will result in traumatic uveitis. They will go and start attacking. Ideally, these are my own antigens. I should never attack my own antigens, but I'm still attacking my own antigens because I never taught my B and T cells in their process of central tolerance and peripheral tolerance. I never taught them only that, this is also present in your body. So if you haven't taught any question to them, how will they know the answer? So they go and start attacking them, and that results in uveitis. That is how a clinical question comes in ophthalmology. So remember, what are the hidden places which I have not exposed to the B and the T cells? The hidden or the cryptic antigens, the brain, eyes and testes. I bet the cells have not seen them. With which we have finished the concept of tolerance. Tolerance was normal for my body, because now when that tolerance shall break, when there is a failure of tolerance, be it central tolerance, peripheral tolerance, failure of tolerance is going to result in autoimmunity. So what is the first autoimmune disorder that I have to know? The very famous systemic lupus erythematosus. Systemic lupus erythematosus, or SLE. Please remember, in SLE, some things that I have already told you, it is a kind of a hypersensitivity reaction, and I had told you to flip the S and the E. I said if you flip the S, you'll get a 2, and if you flip the E, you'll get a 3. So it is a combination of type 2 and type 3 hypersensitivity reaction. But what is it more of? It is more of type 3 hypersensitivity reaction. That is the first point. What else have I already taught you in general path? In general path and in general micro, while doing the complement system, I have taught you this is also associated with early complement deficiencies. SLE is associated with early complement deficiencies like C1, C2, C4. C1, C2, C4. Next question. This has been associated in one gender more. This is more common in females. And has it been associated with some kind of male but chromosomal problem? If you go back to your Klinefelter in surgery, medicine and pathology, Klinefelter syndrome may they ask you which autoimmune disorder is the person at a risk of? The person is at a risk of SLE with Klinefelter syndrome. Also, there is a cell death which can lead to autoimmune SLE. Which cell death is associated with SLE? NETs is associated. I've got you all the SLEs that you studied in path and micro everywhere under one slide. So remember, it's a combination of 2 and 3 hypersensitivity. It is associated with early complement deficiency. It is more common in females. It is seen in Klinefelter patients. It is seen in people undergoing NETs, which is a type of killing. So yes, SLE basic is done. I'm ready for the criteria. There are a total of 11 criteria, and I should actually suffice or have at least 4 for the diagnosis. So repeating, out of the 11 criteria, I should have at least 4 for the diagnosis. So when I say SLE, I'm going to learn it by a mnemonic known as MD SOAP brain. MD SOAP brain is going to have total of 11 things, and I have to fulfill any 4 out of those. Let's start reading. Let me start with M and D, because I am going to make a rule that although there is a mnemonic, but that doesn't mean I read it randomly. I'll try to make a story out of it. So when I'm talking about M and D, the first M stands for the malar rash. The first M is going to stand for a malar rash. What is malar rash? We will all see a picture. Malar rash is a kind of a butterfly shaped rash which you see on the face. But there's something that is very, very important. It spares the nasolabial fold. It spares the nasolabial fold. Have a look at this picture over here. Can you all see there is a butterfly shaped rash? There is a butterfly shaped rash, but it has spared the nasolabial fold. The nasolabial fold is spared. That is not where it's happening. So remember, this is the classical malar rash. Now, once we've analyzed the malar rash, the next rash that we have is the discoid rash. No need for any explanation of it because the name itself is enough. It's going to look as a round like a discoid. It is going to look round like a discoid. So please remember, malar rash, and the other round one is going to be the discoid rash. Perfect. So the 2 rashes are done, means I'm talking about skin problem. So let me talk about one more skin problem, and that is photosensitivity. Photosensitivity is the next skin problem that we have. So repeating, we have malar rash and discoid rash and photosensitivity. These are three skin related problems, because now what I'm going to tell you next are going to be two inflammation related problems, S, O and A. So these patients have serositis. These patients have serositis. Then they have arthritis. And remember, in arthritis, this is a non-erosive arthritis. This is a non-erosive arthritis. No means no joint deformity. There is no joint deformity that is going to occur. And finally, so itis mein ek to serositis, arthritis, itis, and now there is also something known as oral ulcers, because ulcers also have itis only, inflammation hota hai, but these oral ulcers are painless. They are aphthous oral ulcers. They are aphthous oral ulcers and they are going to be painless. Let's do a recap. What is MD so brain? M for malar rash, D for discoid rash and P for photosensitivity. Next we have SOAP, that is going to be serositis, oral ulcers and arthritis. See, MD SOAP is already done. 6 things are already done. I'm just left with 5 more. So what is MD SOAP? And now I start with the next aspect of the criteria, and that is brain. So now I'm actually, first let me finish off brain only. What is happening in the brain in SLE? So N stands for neurological. N stands for neurological, and the patient can suffer from psychosis. The patient can suffer from psychosis. Next, when I talk about B, the B over here stands for blood. So what are the findings that you find in blood? In blood, all the counts are going to be low. All the counts are going to be low. Pancytopenia. What do we mean by pancytopenia? Pancytopenia means the hemoglobin is also low, the WBC count is also low, the platelet count is also low. All the 3 lineages are low. Pan, everything is low. Pancytopenia. And in the blood, we also see something called LE cells. What are LE cells? I will complete this and I'll show you a picture and explain the full pathogenesis. Abhi ke liye learn that in the blood you see a cell called LE cell. Okay, now let's see what do you see in the kidney. R for renal. Renal, obviously. Renal means nephritis. And the name of the disease is lupus. So what is it in the kidney that you're going to have? There is going to be lupus nephritis. There is going to be lupus nephritis. So lupus matlab SLE and nephritis basically means kidney. So lupus nephritis, go to your kidney chapter. You have studied it in too much of detail, but I'll give you quick bullet points here. Lupus nephritis has a total of 6 classes, class 1 to class 6. That is one bullet point. Microscopically, the most characteristic lesion that you get is a wire loop lesion. The most characteristic lesion of SLE in the kidney is wire loop lesion, which you see in which classes? You see it in class 3, 4 and 5. But where do you see maximum wire loop lesions? Maximum. So, dekho, wire has how many alphabets? 1, 2, 3, 4. Loop has how many alphabets? 1, 2, 3, 4. So, which is going to show you maximum wire loop lesions? 4 is going to show you maximum wire loop lesions. Class 4 will show you maximum lesions. So please remember this. When we talk about renal involvement and lupus nephritis, there are a total of 6 classes. The most common microscopic appearance is a wire loop lesion. Wire has 4 and loop has 4. So maximally they are seen in class 4. But they can also be seen around 4. Means class 3 also, 4 also, 5 also. But maximally class 4. Coming to the next. Finally, all said and done, this is an autoimmune disorder. I'm forgetting that. I've not told you any antibodies. So I stands for immunological criteria. What all immunology or antibodies are going to be there, and one of the most important antibodies has been given a different criteria only, and that is ANA, anti-nuclear antibody. So I have to talk about all these antibodies, but before that, I think I have at least made my way through and I have taught all of you about MD so brain. So brain mein kya tha? Firstly, brain ends with N, so neurological, patient has psychosis. B for blood, patient has pancytopenia and LE cell. R for renal, that is lupus nephritis, 6 classes. I for all antibodies, immunological, anti-nuclear antibody. So the first thing that you will ask me is what antibodies? So listen guys. When they ask you which is the most sensitive antibody that you have in association with SLE, so the most sensitive is going to be anti-nuclear antibody. That is why I gave it a separate criteria only, anti-nuclear antibody. If you ask me the next question, that is what is the most specific? Specific may I have to be specific with S. So S has to come and that is going to be ASA, means anti-Smith antibodies. anti-Smith antibodies. So simple, specific में S has to come, ठीक है? Now when I talk about, you say no, I don't want to do alag, separate. I want one antibody which can tell me everything. Which is the antibody which is going to be both sensitive and specific? It can give you a decent amount of sensitivity and specificity. Double benefit. Double is seen with double-stranded DNA. Double benefit is seen with double-stranded DNA, anti-dsDNA antibody. Let's move forward. Which is the one that you see in which there is SLE with psychosis? SLE resulting in psychosis. So psychosis mein you will take out the P from here and the antibody will become anti-ribosomal P antibody. Anti-ribosomal P antibody, right? But now I'm going to put up a case in which SLE has happened in children. What is neonatal lupus? And neonatal lupus is associated with anti-Rho antibodies. How will I learn this? Because I know neonates cry, Rona, neonates cry and Rona. So Rona is going to be obviously anti-Rho antibody. So now all your antibodies become so easy, na? Please everyone repeat with me. Which is the most sensitive? The most sensitive is anti-nuclear antibody. Which is the most specific? S word has to come. Specific anti-Smith antibody, which is going to show me double benefit by double-stranded DNA, which is going to be associated SLE with psychosis. P wala means ribosomal P and neonates cry, so that is going to be anti-Rho antibody. Out of these, which one have I given an altogether separate criteria? That is anti-nuclear antibody. So they ask you that how do you do the detection of anti-nuclear antibody? So for the detection, I do immunofluorescence. That is exactly what I'm going to show you. I am going to show all of you these 5 very important pictures which you might have seen in a lot of your exams and medicine questions. Very important. What are these? This is anti-nuclear antibody that I'm trying to see on immunofluorescence. These are all the patterns that you have to know, the patterns of anti-nuclear antibody. Let me tell you, I'm going to learn it with the mnemonic happens. It happens. Okay, so it happens. So what happens? HPNSC. Happens. So let me tell you, zoom in one by one and tell you. So first and foremost, when I talk about happens ka H, I'll keep writing happens on every slide so that you keep remembering. Happens ka H means the first pattern is a homogeneous pattern. How do you know homogeneous? Because can you see what technique is it? Green color wala immunofluorescence. Can you see that the entire nucleus has become green? The entire nucleus over here has become green. So remember, first is homogeneous pattern. What does it indicate? Why is the entire nucleus becoming green? Because everything in the nucleus is affected, whether it is the chromatin or the histone or the dsDNA. When everything is involved, this is going to result in the homogeneous pattern. Easy to identify, everything is going to be green. Let's look at the next pattern. What was your mnemonic? You were going by happens. So what is the next alphabet? You have P for peripheral. So the second pattern that you have is a peripheral or a rim pattern. Peripheral or a rim pattern. So if you look at it very carefully, at the periphery, the green color is more. Can you appreciate that? At the periphery, the green color is going to be more. When does this happen? When there are antibodies against dsDNA, double-stranded DNA. So remember, antibodies against everything was making it homogeneous, like histone, chromatin, dsDNA, sabka hai, so it is homogeneous. But if it is only against dsDNA, only one thing, then it is going to give me a peripheral or a rim pattern. Peripheral or rim pattern. Let's go to the next alphabet. The next alphabet, what is the mnemonic? Happens. So the next alphabet is going to be N, and that is the third one, nucleolar. When do I get? Firstly, you need to understand what is nucleolar, not nucleus. No, not nucleus. Nucleolar means if I trace the entire nucleus, this must be the entire nucleus. Is that coming green? No. One dot in the center is coming green. So again, over here, the entire nucleus is not coming green. One dot in the center is coming green. That is a nucleolus. And you know, what does it indicate? Nucleolar pattern is when antibodies are against RNA. Again, repeating, nucleolar pattern is when antibodies are against RNA. So nucleolar R and RNA R. Third pattern done. Let's move on to the fourth one. So again, what mnemonic am I following? I'm following the happens mnemonic. So now I come to the fourth one, and that is going to be the speckled pattern. Very easy to identify. Speckled matlab aisa dot dot dot. The nucleus is going to show me this dot 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 kind of a thing, which I can very well see over here. I can see that inside the nucleus there is a dot 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 speckled pattern. Now this speckled pattern, I will realize, is one of the most common pattern. And the most common means every autoimmune disorder is going to show you this. So when I say anti-Smith, I just told you is the most specific for SLE. So you thought, oh wow, this is seen only in SLE. No. Also anti-Rho antibodies, anti-La antibodies. In a short while, I'll be teaching you anti-Rho and anti-La are going to be for Sjogren's syndrome. Anti-Rho and anti-La is going to be for Sjogren's syndrome. So I realized that this pattern is seen with so many antibodies. It's the most common. So it's the least specific pattern. I will get this most commonly in every autoimmune disorder. So that is a question that you get. Please note the speckled pattern that you are talking about. The speckled pattern is the most common pattern, the least specific pattern, because you see it in a lot of autoimmune disorders. Coming to the last one, the fifth one, guys. Which mnemonic were we doing? We were doing the mnemonic happens. Now coming to the last one, that is C, and the C refers to a centromeric pattern. C refers to centromeric pattern. So firstly, no points for guessing. What is centromere? Centromere is the center of a chromosome. I am targeting the chromosome here. And can you all see that there are lots of nuclei where I can see proper arrangement of chromosomes and mitotic spindles, hai na? So this is what you see when there is a antibody specially against centromere. So simple na, anti-centromeric antibody is going to give me a centromeric pattern. Again, such a simple thing to know. Repeating this once again, anti-centromeric antibody. Anti-centromeric antibody is going to give me a centromeric pattern. And where do you see it? Another C, centro itna kara. So there is a syndrome known as the CREST syndrome, which I will be teaching you in 10 minutes. So on that basis, I have done a total of 5 patterns. Let's revise the happens. So let's do a very quick revision of this happens. The first one was homogeneous, in which there are antibodies against all, chromatin, histone, DSD and everything. The second one is peripheral, where there is only antibodies against dsDNA. The third one is N, nucleolar. Nucleolar ends with an R, so there are antibodies that are present against RNA. Next, you have S for speckled. This is the most common, the least specific. There are antibodies against everything again, anti-Smith, anti-Rho, anti-La. All of them show speckled pattern. And finally, we have centromeric, because this I associate with anti-centromeric antibodies, and that is the CREST syndrome. These are all the different things that you had to know, with which, guys, you have very conveniently finished off the MD soap brain mnemonic. But I hope you remember, I had done a promise that I will explain at the end to you what is an LE cell. So MD soap brain ho gaya. What is MD soap brain? You've done 3 things to do with the skin, you've done 3 things to do with inflammation, then you've done all the organ related things in the brain, and you've done all the immunological problems. What is an LE cell? So easy to understand. First, I'll tell you the definition. Dekho, SLE ka S hata do, remove the S. You are left with LE cell, lupus erythematosus cell. LE cell is either a neutrophil, or it is a monocyte which has engulfed damaged nuclear material. That is the definition that is written in the textbooks. It is a neutrophil or a monocyte that has engulfed damaged nuclear material. Damaged nuclear material is also known as a hematoxylin body. So now, whatever the textbooks have written, I have to put some sense into it. Think logically. I have drawn one lymphocyte over here. For example, this is a lymphocyte. Regular, normal cell of your body, this is a lymphocyte. Now, if it would have been you and me, my lymphocyte would have been roaming around normally. But I realized that this patient has anti-nuclear antibodies. This is a case of SLE. The patient has anti-nuclear antibodies roaming around in his blood. Are these anti-nuclear antibodies going to go and damage this nucleus? Of course, they will damage it. Lymphocyte is damaged. It is some dirty, damaged material that is left. This is the damaged nuclear material that I'm talking about. This is the damaged nuclear material. What is the other name for damaged nuclear material that I told you? This is known as a blue color body called hematoxylin body. This is referred to as a hematoxylin body. So at least everyone's understood what is damaged nuclear material. Why am I having damaged nuclear material or hematoxylin body? Because these antibodies का तो नाम ही है ना, anti-nuclear antibody. They will go and damage it. They will damage everything. So I have understood where did this come from. Tell me, do you want to keep anything damaged in your system? Does anyone want to keep anything dead or damaged? No, na. Which are the cells which will always be hungry and will come and eat it? Neutrophils and monocytes. So who is going to engulf it? Remember, these are going to be engulfed by either a neutrophil or a monocyte. So have a look at this. Do you know this is ideally a neutrophil? You'll say, how ma'am? I don't agree. Neutrophil to aisa hota hai. Neutrophil always has these lobes that you talk about. This is a normal neutrophil. Right now, this neutrophil has eaten something. See, the neutrophil has eaten this. This is a hematoxylin body. This is a hematoxylin body. Neutrophil has eaten it. So when neutrophil has eaten a big hematoxylin body over here like this, where will all the nuclei go? The nuclei are going to go and sit somewhere in the periphery. See, these are the nuclei which have come at the periphery because someone else is sitting inside the neutrophil. Everyone's identified how an LE cell is going to look like. That is why I told you the definition right in the beginning, because it comes as a fill in the blank. LE cell is a dash, neutrophil or monocyte, that has engulfed a dash. It has eaten up a damaged nuclear material, which is a hematoxylin body. So please remember, never ever confuse an LE cell with what is referred to as a TART cell. What is the difference between an LE cell and a TART cell? Please note, LE cell for obvious reasons is seen in a disease called SLE, and TART cell is nothing but a normal cell. Sometimes, sometimes there will be monocytes and macrophages that you have. They are anyway always hungry cells. They will engulf anything in the body for a short time and then spit it out. It's as simple. Monocytes or macrophages have engulfed other cells of the body, and that is a very, very normal finding to have, because monocytes and macrophages are always hungry, na? So they can easily do that. So you never have to consider them as LE cell. LE cell is something which you will see especially in SLE. Why? Because it is an autoimmune disorder. It is an anti-nuclear antibody containing disorder. So they look very similar, but TART cell is a totally normal finding and we don't give it any importance. MD soap brain done. LE cell done. Now I have to tell you that apart from these organs that I mentioned in MD soap brain, the 11 criteria, there are some other organs also that are affected. Remember, the heart can be affected, the lungs can be affected, and the spleen can be affected. So this is not a part of the criteria, but this is important. What happens in the heart? Remember, SLE in the heart results in LSE. Rearrange the alphabets. SLE ko I wrote LSE. Means what is it going to cause? It is going to cause Liebman-Sachs endocarditis. It is going to cause Liebman-Sachs endocarditis. Although they say overall, if you consider a case of SLE, pericarditis is more common than endocarditis. But when endocarditis happens, which kind of endocarditis is it? It is a Liebman-Sachs endocarditis. When I talk about the lung and I say, how does SLE involve the lungs? You pick up the SL. You say that these patients show me shrinking lung. These patients show me shrinking lung. So simple, SLE shows you shrinking lung. Finally, what is in the spleen that you notice? You see spleen में skinning. Spleen has skinning. So it shows you the onion skinning pattern around the arteries or the arterioles. It shows you onion skinning pattern around the arterioles or the penicillary arterioles and the arteries. That is what you see. So simple. SLE in the heart shows you LSE. Rearrange the words. SLE in the lung shows you SL, and that is going to be the shrinking lung. And SLE in the spleen shows you skinning. There is onion skinning that you notice. All about SLE has been discussed, but there is one variant of SLE that all of you have to know, and that is drug-induced lupus. Means it is not the real SLE. It is something like SLE, and that has happened because drugs were given to the patient. And what drugs am I talking about? So I have written that in front of you. Those drugs are referred to as the ship drugs. That is, I've got a big ship that has been put up in front of you. We have something known as the ship drugs, and they are responsible for causing drug-induced lupus. So first and foremost, S stands for sulfonamides. This is also a very important part of medicine, sulfonamides. H is going to be hydralazine. H is going to be hydralazine. I is going to be isoniazid. P is going to be procainamide. P is going to be procainamide. and D is going to be dapsone. Let's do a repeat. What is SHIP drugs? So S stands for sulfonamides, hydralazine, isoniazid, procainamide and dapsone. These are the SHIP drugs which can cause a lupus-like situation. Please note, if I have to ask you what is the difference between SLE, the real lupus, and the DIL, the drug-induced lupus, what is the difference between these two? You will first and foremost say that SLE is only and only because of genetic problems, autoimmune disorder. Drugs are obviously because of the SHIP drugs that I am talking about. What are the antibodies? In SLE, I had lots of antibodies, anti-nuclear antibody, anti-Smith antibody, anti-dsDNA antibody, so many antibodies I had, right? Whereas in drug-induced lupus, these are the anti-histone antibodies. These are the anti-histone antibodies that we are talking about. Lastly, what are the organs? Do you remember in SLE we had an entire criteria, MD, SOAP, brain, in which the brain was also getting affected. Remember, kidney was also getting affected, lupus nephritis, but all of that doesn't happen in drug-induced lupus. The brain does not get affected and the kidneys also don't get affected. How will I treat it? We all know that the treatment of SLE, because it's autoimmune disorder, you are going to give steroids. And what is the treatment of drug-induced lupus? Of course, withdraw the drug. Treat whatever is the underlying cause. So you are going to withdraw the drug. Repeating, for drug-induced lupus, you are not going to give that drug, whatever SHIP drug you were giving, you will not give it. The most expected question that I have is, what is the antibody? It is anti-histone antibodies that are important for drug-induced lupus. Done with everything about SLE, and now we are ready to take on the other autoimmune disorders. So the next one is referred to as Sjogren syndrome, very, very famous. S and S, Sjogren syndrome. This is known as the dry eyes and the dry mouth. Think logically. Why do we have dry eyes and dry mouth? What is the reason? There must be some antibodies which are present against two eyes. What would make it dry mouth? Means there are antibodies against salivary gland. There are antibodies against salivary gland, and if antibodies are destroying salivary gland, means saliva nahi banega. Patient is going to have a dry mouth. Patient is going to have a dry mouth. So patient is not going to come to you and say he has a dry mouth. He will say that, I have a bad breath. Patient might come to you with dryness. Firstly, he will say my mouth is always dry and I have bad breath, and that is halitosis. So, because the salivary gland is attacked. The second part that is attacked is the lacrimal gland. And of course, if lacrimal gland is attacked, then no tears will be formed. This is going to result in dry eyes. Patient will not know. He will say again, I'm having dryness in the eyes and I always feel there is some foreign body, some dust particle has gone in. So he will always complain of a gritty sensation that will be there in the eyes. Repeating once again, we have something, antibodies against the salivary gland. So there's a dry mouth, antibodies against lacrimal gland, that is the dry eyes. But can you tell me which antibodies am I talking about? Very simple. Sjogren syndrome, SS. So the antibodies that we are referring to are going to be anti-SSA antibodies and anti-SSB antibodies. And super simple, because anti-SSA is referred to as Rho and anti-SSB is referred to as La. Anti-Rho antibody, anti-La antibody. Which is sensitive? Anti-Rho antibody is said to be the most sensitive and anti-La antibody is said to be the most specific. How will I learn this? Which is sensitive, which is specific? Common sense, guys. Look at this. Rona is considered as more sensitive. Now, the Rona wala is going to become the sensitive antibody and La is going to become the specific antibody. That is what is important for Sjogren. The story is not over. By now, I have learned there's a dry eyes and a dry mouth syndrome caused by anti-SSA and anti-SSB. But how am I going to do the diagnosis of this patient? That is very, very important for me to know. So please note over here. For doing the diagnosis, first and foremost, I am going to do the serology, because by doing the serology, I will find out the antibodies, but that's not it. I also do something known as a lip biopsy. Why do I take a biopsy from the lip? Any reason? The reason is that lip has minor salivary glands, right? So I want to see that are the person's salivary gland and lacrimal gland affected. So I can't take out the entire lacrimal gland or the entire salivary parotid. I will take out a chota wala salivary gland. I will take out a minor salivary gland. You can't take out the entire parotid. Later on, if the patient says, I don't have Sjogren, then he'll sue you for that, right? So you're going to take a minor salivary gland, and that is why you do a lip biopsy. The recent question is, what do you see microscopically? Which cells do you see in Sjogren syndrome on a lip biopsy? We see lymphocytes for the diagnosis. This is the previous year question. Very, very important. What is the cell that you see on a lip biopsy? You see a lymphocyte. Now, guys, is there any place else in medicine that you've studied Sjogren syndrome? Is Sjogren syndrome associated with any other thing? Yes. If you go to your liver chapter, you have studied primary biliary cholangitis is associated with Sjogren syndrome. If you go to your lymphomas, Sjogren syndrome is associated with marginal zone lymphoma. Repeating, it is associated with primary biliary cholangitis, and secondly, it is associated with marginal zone lymphoma. You will read these in very different chapters, but definitely very, very important. This could be your correlation with medicine, path, and other subjects. Very, very important this information is. Sjogren syndrome sorted. If I had to give you 3 questions. Number 1, dry eyes, dry mouth. Number 2, antibodies, SSA, SSB. Number 3, which cell on lip biopsy? So lip biopsy pe lymphocytes are seen. Sorted. Sjogren syndrome done. What do we move on to next? Scleroderma. What is it about scleroderma that we all have to know? Please note, derma means there's going to be involvement of skin, undoubtedly. Sclero, what do you understand by the word sclerosis? Sclerosis means making something stiff or making something thick or hard. That is sclerosis. So when I say there is scleroderma, means the skin is going to become very, very thick. Let me show you a picture. Have a look at this. Sclerodactyly. What is sclerodactyly? You will say sclero means sclerosis and dactyly means digits. Dactyly means digits. So there is sclerosis of the digits. You can see the digits over here. They are looking as if, someone is pulling them. They've become like a claw-shaped digit. Why? Because there's so much of stiffness that has happened. That is what you understand by sclerosis. This can happen anywhere in the body. Not only in the digits, it can happen anywhere in the body. Please remember. So that is known as sclerodactyly. Now I'll tell you what is scleroderma. There are 2 forms of scleroderma that you have to know. One is going to be the limited form and the other is going to be the diffuse form. Limited means there is a limited involvement of skin. There is a limited involvement of skin that has occurred. Whereas diffuse means there is a diffuse involvement of skin that has occurred. How difficult is that to know? Either there is a limited involvement of skin or there is a diffuse involvement of skin that has occurred. So now, limited means maybe one part, diffuse means total body. Which antibody is going to result in it? Limited is caused by anti-centromeric antibody. Limited is caused by anti-centromeric antibody. Diffuse is caused by anti-topoisomerase antibody. Anti-topoisomerase antibody, also known as anti-SCL70. How, ma'am? How can you just write so many things without telling us how to learn this? Don't worry, I'm not leaving you anywhere. So limited means central to a place. Kahin centered hai. It is only limited to one place, centered to one place. So when I say it is centered to one place, which antibody will I use? Centered word wala, centromeric antibody. But when I say the total skin, total, diffuse, total skin is involved, what is the antibody that I will use? Topoisomerase is what I use. And please remember, SCL is the other name because SCL stands for scleroderma only. This in fact is the most specific antibody that you have. Because it was the most specific antibody of this disorder, that is why they named it after the disease only. They called it SCL70, SCL for scleroderma. Let's do a repeat. Whenever I say scleroderma, it's of 2 types, limited or diffuse. Limited matlab limited to the part of the skin. It is centered. Centered means which antibody? Anti-centromeric. But if they say total skin is affected, when total skin is going to be affected, that basically means total matlab diffuse, total, topoisomerase antibody. This is the most specific. So they gave it the name of the disease, that is anti-scleroderma 70. Out of these, this limited form is associated with a syndrome called CREST syndrome. So what is CREST syndrome? Let me explain that to you. Can you all help me with what is the full form of the CREST syndrome that we have? So CREST mein pehle to tell me why am I reading it in scleroderma? Because there must be some sclerosis. There is sclerodactyly that you notice. Digit, sclerodactyly, this picture that I showed you where the patient is having a hand which is looking like a claw. Only digits. So is it involvement of limited part of the skin or total body? Limited part of the skin, only digits are affected. So where do you want to put it? You want to put it under limited scleroderma. Now you've understood why did I put it under limited scleroderma? Because only the digits are affected. So indirectly, for limited scleroderma, if it was anti-centromeric antibody, for CREST syndrome also it is anti-centromeric antibody. Indirect way of asking you the question. What are the other components of CREST syndrome? C stands for calcinosis cutis. Calcinosis cutis. A stands for Raynaud's phenomenon. A stands for Raynaud's phenomenon. E stands for esophageal dysmotility. The esophagus also has sclerosis. There is a problem in eating, difficulty in swallowing. And T for blood vessels have a problem known as telangiectasia. I'm going to repeat this once again. When we talk about C for calcinosis cutis, R for Raynaud phenomenon, E for esophageal dysmotility, S for sclerodactyly, T for telangiectasia. That is what is CREST and comes under the limited form, means it is going to show you which antibody? Anti-centromeric antibody. Scleroderma okay with everyone? No problem at all? Yes? What are the last set of things? I'm going to mix everything. What is that mixture known as? Mixture matlab, I am going to call it MCTD, mixed connective tissue disorder. You will say, ma'am, everything is mixed. Isme little sclerosis ka features are also there. Little SLE features are also there. Little muscle involvement and polymyositis is there. Basically, it's a mixture of a lot of autoimmune disorders. So I call it mixed connective tissue disorder. So I have only one treatment that I can give to so many diseases, and that is steroids. The only question that you'll get is what is the antibody in it? The antibody is anti-U1 RNP antibody. So remember, ribonucleoprotein U1. Ribonucleoprotein is all that you have to know over here. So how I have learnt it is mixed connective tissue disorder U1 ribonucleoprotein. Ye 4 alphabets, 4 alphabets wala antibody. I'm going to keep it together. Repeating, mixed connective tissue disorder shows you U1 RNP antibodies that are positive, and the treatment is going to be steroids. Everyone's okay with the MCTD? Quick one, right? Last one that we have is the difference between, since I spoke a little bit about myositis, I thought why not study these also over here. A quick discussion of all the myositis that we have. What are the 3 myositis in medicine that you study? Polymyositis, dermatomyositis, and inclusion body myositis. Let me start with the first one. The first one that I have over here is going to be the dermatomyositis. So firstly, myo I have understood. There is going to be involvement of the proximal muscles. This much I have understood. There is involvement of the proximal muscles. Derma, I understand that there is involvement of dermatology, there is involvement of skin. So I can actually see that, okay, proximal muscle weakness, to theek hai. Patient will say that he's unable to get up, difficulty in getting up, doing day-to-day chores. That is okay. Derma, skin related kya hai? What are all these things that we can label out? First and foremost, I see a rash around the eyes. And what is that known as? That is known as the heliotrope rash. This is the heliotrope rash. Then I see some papules that are present on the knuckles over here and also on the phalanges over here. These are referred to as Gottron papules. These are referred to as Gottron papules. Then I see the same rash on the skin of the neck and the back. So basically this is the area where a shawl is worn. Shawl, you must have seen people who like to wear a shawl. They usually wear a shawl over here, na? So on their shoulders. So that is a shawl sign. Same rash you see as a V-shaped sign on the neck. So either you can call it a V sign or you can call it a necklace sign. And lastly, you see the presence of this really cracked hands. What are these cracked hands known as? These are referred to as mechanic hands. hands. I'll repeat this once again. Please note, you can see a rash over here, that is the heliotrope rash. Then you see these Gottron papules. Then the shawl area shows you the shawl sign. The neck area shows you the V or the necklace sign. And you get to see these mechanic hands, that is dermatomyositis. What are you going to see if I do a muscle biopsy? What do you see on a muscle biopsy? So please remember. So what is the muscle biopsy of dermatomyositis going to show us? First and foremost, if you see all the inflammation. So were you able to analyze that this is a muscle biopsy in the first place? How did you analyze that? Because you could see these round cut muscle fibers. These are all the muscle fibers. But you will definitely see something, that all the inflammation, the lymphocytes inflammation is at the perifascicular area. So all the inflammation is going to be perifascicular, around the fascicles. And not only that, you will see that because of this inflammation, there is also perifascicular atrophy that has happened. I've got you another picture where you can easily visualize that some of the muscle fibers in the center were bigger, and then as you went to the muscle fibers at the periphery, the muscle fibers have become very, very small. Can everyone appreciate? This is known as the very famous perifascicular atrophy. This is known as perifascicular atrophy. That is what you see in dermatomyositis. Repeating once again, the myo component is proximal muscle weakness. The derma component, I've shown you a lot of pictures. When you look at the muscle biopsy, on a muscle biopsy, I can see two eye findings. Both of them are around this thing, around the fascicle. So the inflammation is also over here, perifascicular, and all these fibers are going to become small. Those small are going to be perifascicular atrophy. What are the antibodies involved in it? There's a long list of antibodies for dermatomyositis. Even for polymyositis, the same antibodies come. So anti-nuclear antibody comes everywhere, so that has to come. Jo1, Mi2. So Jo1 antibody positive, Mi2 antibody positive. Especially Mi2 is the one responsible for a lot of skin features, the skin derma features. Mi2 is associated with it. So next, please remember, we have anti-P155 and anti-P140. So when I'm talking about anti-P155, that is associated with a lot of paraneoplastic syndromes, and anti-140, the chota wala number with chota wala children, that is juvenile dermatomyositis. So a lot of numbers that I've written. First I've written 1, 2, then I've written 140 and 155. So what is 1, 2? Jo1 Mi2. Jo1 Mi2, out of which Mi2 is responsible for all the derma related things. Then I've written the anti-P140 and anti-P155. So chota wala number I'm going to include out of these for juvenile dermatomyositis. And P155 is associated with big syndromes called paraneoplastic syndromes. You just have to go through these antibodies. They are all seen with dermatomyositis. They can also be seen with polymyositis. So how will I differentiate dermatomyositis from polymyositis? Please note, when I say polymyositis, there is only muscle involvement that I have to focus on. There is a proximal muscle weakness that I have to talk about over here. Is there any derma problem? No, the derma word is only not there. There is no heliotrope rash, Gottron papule, shawl sign, V sign, mechanic hand, nothing. No derma thing. Only proximal muscle problem. So how will I differentiate this from dermatomyositis on a muscle biopsy? Do you remember in dermatomyositis, everything was at the periphery. The inflammation was also at the periphery. The atrophy was also at the periphery. Here you see inside. Can you see those dot? They are in between the fibers. You can see if this is a muscle fiber, this is a muscle fiber, this is muscle, this is muscle. I am seeing that the inflammation is endomysial. There is an endomysial inflammation that I see over here. And is there any atrophy or anything happening? No, there is no perifascicular atrophy. So repeating, in dermatomyositis, there was a perimysial. On the side, there was the presence of inflammation and the fibers were becoming smaller. There was perifascicular atrophy. On the other hand, in polymyositis, you've gone inside. There is endomysial inflammation, like you see over here also. There is endomysial inflammation that is noted. There is no atrophy that is seen. We've done two myositis in which the proximal muscle was getting affected, polymyositis and dermatomyositis. Because guys, there is another myositis known as IBM, inclusion body myositis. This is going to occur most commonly in the elderly, in old people, and this is going to involve the distal muscles. So simple, it's going to happen at distal age, very, very high age, and it's going to involve the distal muscle. So end of life pe hoga, end of muscles mein hoga. Easy. It's going to happen in the end of life and it's going to happen in the end of the muscle. So elderly and distal muscles, the polymyositis and dermatomyositis were proximal muscle. Coming back, why do I call it inclusion body myositis? There must be some inclusion present. What is the inclusion? Yeah, I could see there is some round structure in the center. So basically, the muscle tends to show you rimmed vacuoles. The muscle tends to show you rimmed vacuoles. I was very, very curious that, okay, what are these rimmed vacuoles? So what is the stain that I do for a muscle biopsy? I do the very famous Gomori trichrome stain. Whenever you see a different color for a muscle biopsy, you will see Gomori trichrome stain. Over there also I saw that, yeah, there are genuinely some rimmed vacuoles that are present. These must be containing some inclusions. You know what inclusions do they contain? They contain amyloid-like inclusions. So they are going to be positive for what stain? What is the stain for amyloid? The stain for amyloid is Congo red. So they are going to be positive for amyloid-like inclusions. So amyloid wala stain, that is Congo red positivity. So only 3 questions that you need to know for inclusion body myositis is, it happens at the distal age, that is end of age, elderly. It occurs in the end of the muscles, that is distal muscle, and it shows you an inclusion, and that inclusion is nothing but something containing amyloid. So that is Congo red positive. We have finished all of our autoimmune disorders. We are ready for 3 quick questions. Which of the following hypersensitivities can be noted in SLE? Can you recall for me? I gave you a mnemonic also. How do you settle SLE? Flip the S and flip the E. So you're going to get 2 and 3. So what is your answer? It is a combination of 2 and 3. Next PYQ. Which of the following inflammatory cell is more commonly seen in a lip biopsy of Sjogren syndrome? Lip, L mein L. Lip biopsy was showing you which cell? Lip biopsy was showing you the lymphocytes. है ना?